Hello and welcome to Queen's University Belfast's latest Research to Reality Roundtable. Today we're covering the topic of cancer and caregivers. Quite correctly, there's a lot of focus on the latest research into developing treatments for various forms of cancer. But we tend to hear less about the stresses and strains which living with a serious diagnosis can put on patients and their loved ones, the families and caregivers who have to embark on a difficult journey together. All the Queen's academics here with me today are working to reduce the discrimination experienced by cancer patients and to develop better resources and policies to improve all-round support for both patients and their families. I'm Mark Devenport. Let's meet our guests. From the School of Psychology, I'm joined by Professor Martin Dempster. From the School of Nursing and Midwifery, Dr. Olinda Santin. And from the Patrick G. Johnston Centre for Cancer Research, Professor Mark Lawler. This cross-disciplinary group of guests will provide us with different views on our topic, spanning the fields of medicine, psychology, nursing, and public health. Much of the research we'll be covering aligns with two of the United Nations Sustainable Development Goals. Number 3, which concerns good health and well-being, and number 10, which refers to reducing inequalities. If we can start by giving the audience a bit of an idea of how you got to where you are today, Martin. You're a psychologist, originally from Ballymena. What took you into the psychology of cancer?
Whenever I started at my undergraduate degree, psychology wasn't directly an option. It was only through doing an additional module at the undergraduate degree that I've realized that actually psychology is something I was a bit interested in. And thought, well, that's something I want to pursue further, and did my PhD. Interestingly, none of that was in the area of health psychology and working in the area of health. So it was only post PhD whenever I got a job working in what was known at the time as the Health and Healthcare Research Unit, which is part of the Faculty of Medicine in Queen's. And so I sort of fell into the area of health and how to apply psychology in health. What I realized then was that psychology can be quite useful in terms of helping people manage the consequences of health. And we started off working in heart disease and other conditions. And it was only, I suppose, later in the process, maybe about a few years into that job, that I was introduced to people who were working in cancer. And that's what got me involved in that. So it was fortuitous rather than any sort of plan that I had. So yeah, that's what I fell into.
And I gather you were actually lecturing at one point. Olinda, our other guest here, was she a good attendee of your lectures?
Best student.
I let Olinda say about her own attendance, maybe, because I wouldn't like to speak for her, but I think that was at the time when we were doing the cancer
module. I think it was the first cancer module kicked off.
So that was at undergraduate level.
Yeah.
It was that module that led us to develop what we now have as a master's in clinical health psychology with quite a focus on cancer in that master's. So it was people like Olinda, I suppose, that their feedback from that module that encouraged us to develop it a little bit further.
Yeah. So Olinda, you're originally from Derry, and then, as we were saying, you went along to lectures of Martin, amongst others. He can't be too off-putting.
Absolutely not, no. And obviously my attendance was 100%.
Even in those very early morning lectures.
Yeah, absolutely. It was always first in, front row.
But what interested you about the topic then?
I always wanted to be a career that would be helpful, and I was always interested in health, but never had the sort of head or the stomach for medicine or nursing. So I wanted to enter a career that would be helpful for people who were living with long-term illness. And I think through studying at Queen's, I got a real interest or knowledge in how an illness like cancer can have these long-term impacts, and not only on patients, but on families, and how as psychology as a discipline can help slot in interventions that can make that process a wee bit easier. And I think that that's what really kind of got that fire in my belly at that time. And when I was studying at Queen's as an undergraduate, in my final few months, an advertisement came around that there was a PhD that was opening up that wanted to focus on understanding the long-term psychological impact that a diagnosis of cancer can have. So I was really lucky that I went for that interview, got on the PhD program at Queen's, and that's really been my research focus since that. And I suppose my interest has just continued to build.
Because prior to that, you were actually, I think, looking into the area of looked after children, but you were able to apply maybe some of what you studied or learned during that experience to look at the stresses and strains on cancer patients and their families.
Sounds very different, but it's actually really similar. I worked for an organisation called VOIPAC, which was Voice of Young People in Care, and I worked as an advocate for children who grew up in the care system, so who either live in foster care or at home or in children's homes. And a lot of what we were doing in that job was listening to needs and issues and then trying to work together collaboratively to build solutions to make life better. So a lot of my work now that would work on co-designing or co-creating solutions actually was inspired from all that work that I did with children and young people. So all those skills really transferred over, and I was able to take them forward into my research on cancer and how we can work with families and healthcare professionals.
Now, Mark, whilst Martin and Olinda have come through, if you like, the psychological route, your journey to where you are today was very different. You were a geneticist and you were working south of the border in Dublin.
Yeah, Mark, yeah. So my interest was really science. So my dad, I was from inner city Dublin. None of my family had ever gone to university, but my dad was very interested in science and biology and nature. And so, for example, we'd be going down to the canal and collecting beetles and fish and that. So we didn't have a tropical tank. We had a tank that was actually filled from the local canal. But then I went to Trinity and did an undergraduate degree in genetics. And that's how it got me down the genetics route. And it's interesting what both Martin and Olinda say. Sometimes it's actually very difficult to plan your career. So I went to Trinity because it was in the centre of Dublin. It was good fun, but it was also the only place in Ireland that you could do genetics as a degree, which I didn't know when I started the science degree. And then a chance meeting between, I then went to the States, did a fellowship there, was going to do a PhD in the States, and then came back subsequently because Peter Humphreys, who actually ironically was in genetics in Queen's, came to Dublin, and I ended up doing my PhD with him. And then the third sort of happy accident or serendipity was he then met another person called Sean McCann, who was a hematologist, and that's where the genetics and cancer came in. I suppose that was really when I started on my sort of true vocation, was bringing sort of the skills and the interest in genetics, but applying it in the cancer field.
Genetics is really an area where cancer research and treatment is at the moment being revolutionized, because the layperson can think of different kinds of cancer. They think of lung cancer or pancreatic cancer, but the genetics is really digging down into individual tumors and being able to look at them in that kind of individual way and then shape the treatment, isn't it?
Yeah, so essentially we're now classifying based on genetics and molecular, and that means that there may be 10 or 15 types of breast cancer, for example, based on the genes, which are turned on or turned off, and that means that you can then start to think about, well, how do we target those genes? So if that gene causes the cancer, can we actually target it and use it as a treatment? And the idea of what we call precision oncology or personalized medicine is exactly that approach. And we were lucky to be in near the start of that, and that sort of revolution, if you like, that overtook medicine, particularly in relation to cancer.
And your decision to move from Dublin up to Belfast actually had a lot to do with Patrick Johnson, whose name is now given to the Centre for Cancer Excellence, research excellence here in Belfast.
I would have known Paddy very well. We're in the same community. The cancer community on the island of Ireland is relatively small at that time. This is sort of 10, 15, 20 years ago. And he gave me a call out of the blue, said, I'm going to be in Dublin. I'm flying out from Dublin Airport. I want to chat to you. I have a proposition for you. And that proposition involved me coming as a visiting professor here to Queen's for a day a week for about 14 months. I actually stayed with Paddy, so I used to come up on a Tuesday evening on the Enterprise, go out to Four Winds where he used to live, stay with him and his family, have dinner, and then go in the next day with him, work that day, and then come back to Dublin. And then during that time, then I guess they decided they liked me. I decided I liked Queen's. A position came up, and it was the best decision I ever made in my life.
Olinda, whilst everyone will understand, certainly anyone who's had any body who they love to has been affected by cancer, that's going to lead to sort of stresses and strains within the whole family circle, the whole circle of carers. I imagine it is different in terms of the different individual condition, the different ages involving the patients, the different prognoses of different conditions.
Mm-hmm.
So in that sense, every case is unique.
Yeah, but there are common factors that run through all, that it's tough. If you have someone you love or care about that gets a diagnosis of cancer, wherever that is in the body, whether that's at an early stage or a late stage, whether that's your mom or your wife or your husband or it's going to have an impact. We know that from the research, and we can see that those impacts can be physical, lots of people having poor sleep, weight loss, fatigue, psychological, living with anxiety, low mood, worry, always worried that this will lead to losing that person you care about. There are people living with real social implications, changes in jobs, trying to manage kids, trying to manage life, trying to manage your relationships. So yes, there's differences, but there are these common threads that run through. And one of the really lovely things about the research in Queen's that we do, that we look at this research in all different countries throughout the world, and whether you're here in Belfast today, or you're in Vietnam or Australia or somewhere in Africa, if that person you care about is diagnosed with cancer, it's tough, and you need help and support.
Because I know that what both of you have been doing is not just looking at the situation, looking at the challenges faced by cancer patients and their families, but also seeking some kind of intervention, be it through the use of digital technology or... Can you tell me about that?
So, because you were asking Martin about who the different people that may have been inspired, and some of the development of digital resources for families affected by cancer actually was inspired by being told by carers that some of the ideas I had were terrible. So as someone with a background in psychology, I knew that carers needed support. And we went off to the cancer centre one evening, and I, as an academic, suggested 12 weeks CBT, cognitive behavioural training. This is what could help. And the healthcare professionals started asking interesting questions like, who's going to deliver that? Who's going to pay for that? How's that going to fit into our service? But the carers were saying, that's not what we want. We can't have another appointment to go to when we already have to be at the hospital twice a day. So having that feedback that idea wasn't working actually helped us to sit back and to think about, well, what should an intervention look like? What would be helpful? What could fit into the health service? And that is where that conversation started about how can we work together to develop digital solutions? Because carers said to us, we don't want another intervention that will burden. I want something that I can have on my phone or on my computer at 11 o'clock at night when I've got the kids to bed and my wife is asleep and we've eventually got the dishes done. I can't go to the hospital again for another appointment. So having that sort of feedback and people telling you that your ideas aren't good and listening to them actually really shape that development of those co-designed digital solutions.
Martin, I know that you've had interventions as well, particularly in the field of esophageal cancer. Can you tell me about that and why you honed in on that area?
Yeah, so esophageal cancer was an area, again, like an area that I've fell into fortuitously from a conversation with a gastroenterologist who told me about this cancer that I had never heard of before at that point in time. And how it impacted on people's lives. And it's not just the cancer actually that impacts on people's lives, it's the treatment because of the surgery that takes place and they have to cut out the tumour from the esophagus. Stomach has to be stretched to meet the remaining part of the esophagus. So it creates issues with regurgitation, for example, and difficulty swallowing and so on, which in turn creates difficulties for people in social situations where we often have food. That can create difficulties for people in that situation. And I thought, that's a very interesting psychological problem, that people who have actually gone through this surgery in the hope that they will be cured, and often are, from esophageal cancer, are now left with this legacy of feeling awkward in social situations, but also all the symptoms that they really experience. And how do they manage that odd situation of, where people may be saying to them, well, isn't that great now you've been cured with your cancer, but actually they're not feeling great at all, feeling quite down on a lot of occasions and having to adjust their behavior as a result. So those things I thought, well, how can we help in that situation? What are the things that we need to focus on and help with? And that's when I got involved then with one of the charities. It was at the time Esophageal Patient Support Group, which was a UK-wide charity at the time. And that's when you get to have a chat with the people who are actually going through this and experiencing it, and then through the research that we did, developing a way of finding out what is it that most contributes to your anxiety or your distress. And the work that we have done in that area is really focused on illness perceptions and this concept called illness perceptions. And what's interesting about those illness perceptions is that they will influence your behavior and in turn influence how you cope with that, and therefore the psychological outcomes like anxiety and depression and so on. So the research that we have done has identified which of these illness perceptions are the most potent in terms of those outcomes, which are the ones therefore that we need to change, that we need to focus on in any intervention. So things like controlling the illness. Esophageal cancer is not something you can control, but people feel that they have to do something to control it. So when we know that through the research that we've done, we can look at interventions that help people to let go of control. And you need to live your life to the best way that you can, despite the fact that you can't control this condition. And for lots of people, that's relieving. Psychologically, that's relieving to just realize that. It's a simple thing, but just understanding that and realizing it. That's the type of research that we've done in that area, and the types of interventions that hopefully will help people to manage that situation in the future.
Mark, when we sort of were discussing how you got into this and talking about your background in genetics, people might have then formed the impression that you're the guy looking down a microscope and with the white lab coat on and not having contact with the public. Actually, nothing could be further from the truth, because your career arc has taken you very much into working with patient groups and very much into matters of public policy.
Yeah, no, absolutely. So, I mean, I did do the lab coat and the chest tubes and the Eppendorfs, etc. But then when I came here, Paddy said the first thing he wanted me to do was actually to think about data. And actually, because at the time we were doing lots of experiments, but we hadn't actually thought about how do we collect the data, how do we use the data. And that first project that I worked in was actually looking at collecting data on cancer inequalities. So we looked right across Europe. It was the biggest study at the time on cancer inequalities. And what we found was, key inequalities, socioeconomic inequalities, inequalities in relation to access to services, access to diagnosis. And what was particularly important was that was then able to inform us in terms of what we were going to do. I very much agree with Mark and Olinda. I don't do science for science sake. I do science to get a better impact that actually can benefit patients or their families. And so what we did was we said, okay, what can we do here that will have the most impact? We have this data, we have this great study we've done, it's the biggest study at the time, but how do we use it? And so what we said was, well, why don't we use it to actually sit down? So it was co-created between health professionals and patients. And why don't we sit down and say, what should patients get from this? So rather than thinking about what health professionals or researchers or whatever, and what we decided to do was create a European Cancer Patient Bill of Rights. And so we sat down, co-created that together, and these are the rights that cancer patients should expect, no matter where they lived, no matter what socioeconomic background they were from, no matter what disease they had. And so we launched the European Cancer Patient Bill of Rights on World Cancer Day in 2014. At the same time, we published the paper because we needed the evidence base, and we published that in Lancet Oncology, which to my mind is probably the best cancer journal in the world. So we had the evidence, but most importantly, we had the people. We brought 50 people to Strasbourg, and I can talk about that because that is very challenging. I thought it was definitely going to be in Brussels because 3 out of 4 times the European Parliament sits in Brussels, but this one particular day, World Cancer Day 2014, it was in Strasbourg, and we actually presented our case in front of the Parliament. And then got the health commissioner at the time to officially launch the European Cancer Patient Bill of Rights. That's had huge resonance right throughout Europe. People have taken it as a beacon of hope. They've used it in their own countries to drive change. And so I'm really proud of that. But it's come from generating the evidence first and then using that evidence then, in this case, to benefit patients, to support patients, but also to influence policy. And I sometimes say, it's data, not opinion. In fact, data eat opinion for lunch. We make too many decisions based on opinions, and there might be opinions from very learned, grey-backed professors or grey-haired professors like myself, but we need to have data to back that up.
One theme in a lot of the areas that you've worked on has been collaboration across international borders, hasn't it? Whether it's been across Europe or between Britain and Ireland, or indeed across both sides of the Atlantic. I mean, you see that as very important in terms of harnessing data, getting it to lead towards solutions.
Yeah.
But there are challenges because obviously there's a bit of a kickback occasionally now. For instance, since the European Charter of Rights, we've had Brexit and so on.
No, absolutely. So one of the things we realised was that cancer knows no borders. And really that was a key sort of principle that a lot of the work we've done is based on that. In Northern Ireland was a great example of this. Back in about 10, 15 years ago, in 2013, we managed to get to a situation where we had the best outcomes for breast cancer in the UK. Why was that the case? Because we focused on breast cancer, we improved screening programs, we introduced cancer research. So again, it's getting knowledge, but using that knowledge to learn. And I'm a big believer that we all have something to contribute. So, I mean, I was so proud, for example, presenting at the Science Summit of the United Nations General Assembly to show that Northern Ireland is a brilliant example of the health dividend of peace. Because actually peace, and 25 years ago when we saw, or 26 years ago when we had the Good Friday Agreement, that led to an agreement a year later between Ireland, Northern Ireland and the US Cancer Institute, National Cancer Institute. And that's had a huge impact on this island of Ireland to allow us to actually work together. So, and the other thing is, it gets very much back to what Olinda, it's multidisciplinary. We all work together. We don't work in our own little areas now and working away, and we need to work together because it's the whole person. We're now thinking much more of cancer in terms of how can we control cancer but still give good quality of life. So the emphasis just on cure, which would have been the case 10 years ago, has now changed completely. Because we don't want to be cured, we want to also have good quality of life. And sometimes there's a balance between those two. So maybe controlling the disease, but making sure that either the physical effects, side effects of treatment, or the psychological aspects are taken into play. Because every cancer patient is a person, and they have physical things, mental things, and we need to be taking that into account.
Yeah, because you've worked obviously at an international level, as you were saying, Europe, the UN. I know you were working on the UK National Cancer Strategy with the Health Secretary just a couple of weeks ago there. But it's very important to you to see that individual cancer patients and their stories shine through and shape policy.
Yeah, it's really important. So if you just use the numbers, so if you just say data is numbers, then I think you're losing the battle in a way, because people fog over, glaze over. But if you're saying this is evidence, and this is evidence to provide, so a great example is working with Bell Cancer UK, so UK Cancer Charity, and there was an inequality essentially that patients were being treated with a specific drug in the UK, particularly in England. And if you wanted to, for example, recommend that this patient is taken off that drug for a while because there may be some toxicity associated with it, you weren't allowed to put the patient back on the drug again. The patient would go off the program. Patients were scared stiff in relation to, I'm getting this drug. And so what we did was we said, well, can we look to see whether being on the drug all the time, so what I would call continuous infusion of the drug, or intermittent, where you're getting it sometimes, but you can come off it for a period of time. We showed that the two of those had exactly the same outcomes. We also showed that You probably had slightly less side effects if you did the intermittent approach. We also showed the patients emphasizing that for them, this intermittent approach was better, so patient stories. But actually the sort of critical piece of evidence was the health economic evidence. I know that's unfortunate to hear in this situation. You would hope that the patient testimonies would go on, but it was that combined with the health economic approach, because the health economics showed that we could save the NHS 1.2 billion. And that was the key piece of work that allowed us to actually change the policy. So there's a great example of research changing policy to benefit patients.
Olinda, we were talking earlier about the importance not just of analysing the challenges facing cancer patients and their caregivers, but also working on practical interventions. Can you tell me in a bit more detail about the programme that you've worked on, which has been applied both here in Northern Ireland and elsewhere around the world?
Yeah, absolutely. So we were involved in a piece of, a big piece of research. It was a population-based study that told us that our carers were struggling. That if we looked long-term, we could see that there was psychological and social consequences of supporting someone who have had cancer. And really by identifying that problem, we went out into the healthcare system and we said, our carers are in need, they're really struggling. Why is that? Why is there a gap in the health service? And what healthcare professionals told us at that time, they said, absolutely, you're right. Our health service is so overstretched, it's so under-resourced that in that 10 minutes that I have to focus on the patient. And I can see that mum or dad or husband or wife has lost weight, or they're not sleeping, or they're teary, but I have to focus on the patient. So together, really, from both the data from the research, from working with healthcare professionals, we came up with this idea that, well, we need to think differently. Carers need support, but our health service is really stretched and under-resourced. So slotting in another intervention in a really burdened service, probably not a good idea. So we had a huge group of carers from across Northern Ireland, various healthcare professionals, again, across Northern Ireland, general practitioners, voluntary agencies, who sat round the table on multiple occasions to really have that discussion or iterative development of how can we best support carers. And one of the ideas that came was the resource called Cancer Caring Coping. The idea was to have a one-stop shop, a digital resource that provides support and information across the trajectory. So today, if I'm at diagnosis, I can click on that resource and get information and support tailored to me today at diagnosis. Because what carers told us was that often on the day of diagnosis, you might get a suitcase full of information. And the first thing you do is you pick up the one on death or palliative care or bereavement. So psychologically, you take yourself somewhere that maybe you don't need to be. So the idea behind the resource that we built was to deliver information that is tailored to where you are. So if your loved one is going through treatment, you can provide information and treatment depending on what stage. We also have information on how to talk to kids about when someone is diagnosed with cancer. How do you manage the finances? How do you manage talking to employers? So that idea of cancer caring coping, that on the day of diagnosis, the family member should be signposted to that resource. That resource, or that idea about delivering peer-led support and information at the point of the trajectory has been really successful. And in Queen's, we've led a program of research which has developed that in Vietnam, in Australia, and currently we're in the process of delivering that resource in Colombia as well. So it has been an idea that different countries have really seen that has value within their space as well.
How do caregivers go about accessing that?
The idea is that when someone is diagnosed with cancer, there is a patient information pack given on that day of the first diagnosis, they are signposted straight away. We also do lots of different ways through social media, through posters in hospitals, through leaflets to make sure that that resource is out there.
And Olinda, did you find in different countries when you were introduced, I remember you telling me about this in Vietnam, I think it's an amazing program. Did you find that there was sort of different nuances or different things you had to concentrate on, or just different ways of doing things because of, I guess, cultural differences between countries?
Yeah, absolutely. So for example, the resource here in Northern Ireland is peer-led, so that you will have carers who are giving the support and information. In Vietnam, our carers wanted that to all come from healthcare professionals. So the information and the support and advice was directly from healthcare professionals. But depending on country, really depended on the need that we wanted to focus on. So we're in Northern Ireland, we really focused on emotional and social support. In Vietnam, what carers wanted was skills training and education. How do I wash somebody who's really sick in bed without them getting cold and without me getting the bed wet?
Yes.
How do I feed someone who's really sick? Do I give them water in between? Do I not? So
it's really practical
so
examples,
So that was what carers wanted to know. They just wanted to know, when someone is sick, what can I do to make this process better? So when you look at the different versions around the countries, there is modifications and adaptations to make the cultural and context.
Martin, because if you go onto the web, there's a lot of misinformation and disinformation about cancer, unfortunately, out there. But this is an example that Olinda's telling us about using technology to spread good, useful information and maybe make it specific to a country or to a particular condition.
You know, the nice thing about this work, I think, is that this came from the carers, you know, as Olinda was explaining, it came from where people were saying, actually, this is what we want. And, you know, so that's a very powerful story. This has been created by the people who actually need it. So that really helps. And it's giving the information that is relevant. As you say, there's a lot of information out there in the internet which might not even be true, isn't always presented in a way that's most beneficial for people at the stage they're at in that journey through cancer. And again, the nice thing about the resource here is that it's staged in a way, it's phased in a way that people only access the information that they're ready to access.
I presume in terms of giving support to caregivers, we have to have a balance of, I suppose, human intervention. People want people who are there in the flesh that they can trust, and also what's available on the web.
Yeah, I think choice is the important thing. That we see this with other illnesses, but choice is the important thing for both patients and carers. There are burdens associated with caring, and of course, people who are in that situation won't even recognize that. They won't refer to it as burdens often. They won't recognize that quite a lot of their time is being taken up by doing things, not just because they have someone in their family who has cancer, but because they've all the other things that they're trying to manage in their life, and this is something else. This is an additional thing, and there are financial difficulties associated with that too. So if we try to impose a one-size-fits-all solution to people, if we try to say, this is okay, so you have to go for therapy or you have to see a person once a week for, you know, whatever number of weeks, and it will only happen in a 9-to-5 situation. Well, that's just not going to work for everyone. For some people, that is exactly what they want. For some people, that's really beneficial, but for others, it's not. And so choice and making it fit with everyone's lifestyle is the really important thing here.
Mark, in terms of the challenges facing cancer patients and their families, there are very many of them, but financial challenges can be very significant, including discrimination, which can even last after somebody's been successfully treated for their condition.
Yeah, Mark, I'm going to tell you a story, okay? So Marie from Bordeaux and Mary from Ballymena. Both of them diagnosed with breast cancer, both devastated by their diagnosis, both treated, both 5-year survivors. Marie wants to buy a little house in a hamlet in Gujanak. She goes in, gets her insurance, gets everything, buys it, is happy there, settles down there, loves it, goes there every weekend. Mary wants to do the same up in the northwest of Northern Ireland, goes in and finds her premium is extortionate, and it's just not going to be possible at all. Both of them diagnosed with breast cancer, both of them 5-year survivors, and yet a complete discrimination between what's happening to Mary in Northern Ireland and what's happening to Marie in France. Why is that the case? Because there's discrimination in Northern Ireland, and in fact on the whole island of Ireland, against cancer survivors who've survived their condition, so they've done amazingly well to be 5 years post. We would consider them cured. However, the insurance industry does not have that view. So who do you believe? The doctor who says you're 5 years out, you're cured, or the insurance company? But that's the situation at the moment. So we call it looking at ways in which we can get around this to be the right to be forgotten. So what we want for survivors who are 5 years or more post their treatment, successful treatment, and that they don't have to disclose their previous diagnosis because they're now back in society, they're working, etc. So their risk of actually getting cancer again is very little. And so what we're saying is, and we're reaching out to people who've had this situation in Northern Ireland, please tell us your story. If you've been discriminated against in relation to financial discrimination simply because you had a previous diagnosis 5 years ago or more, we want to hear from you. Because we want to change this. This really makes me angry. And again, it's based on using evidence that we've collected to show what's happening. And we want to collect more evidence to show and to look at Northern Ireland leading a UK crusade against financial discrimination against cancer survivors.
What kind of products is it then? Is it mortgages, travel insurance?
Travel insurance. So again, you think about it, travel insurance, people want to get away from the thing in relation to being a cancer survivor. They want to be part of normal society again. They go to try and go away on their holiday. They're being charged 2, 3, 4 times. Irish Cancer Society have shown that 3 out of 5 cancer survivors are being discriminated against. It's just not acceptable. We've presented this to the All-Party Group on Cancer in Stormont and also the similar body in Leinster House in the Republic. And we're determined that we're going to change this. But we need to hear from people who've experienced this, because the more evidence we have, the more stories we have, the more we can be successful to really change this inequality.
And which countries have this right to be forgotten
so France,
in relation
the reason
to
why
cancer?
I took France as the example, France was the first country in the world in 2016. There are now 9 countries in Europe who have all introduced this right to be forgotten as a legal instrument. And that's really important, because it means then that it's against the law to actually ask for your cancer diagnosis after 5 years. A number of countries, including in the Republic of Ireland, have introduced a code of conduct. But the insurance industry can either go by the code of conduct or not. There's no penalty for them. There's a penalty for the cancer survivor, but not a penalty for the insurance industry. So we want to change that. And the only way we feel we can change it is by having that 5 years, which we think is reasonable, and also that it's a legal instrument.
Olinda, in terms of international comparisons, obviously the conditions facing cancer patients and their caregivers in countries like Vietnam, where some of your work has been applied, are very different from, say, in the UK or Ireland. You've been able to work with those countries through development assistance, but unfortunately that's been cut back a lot, hasn't it?
Yeah, that's been really one of the tricky things is as part of our research here in Queen's, that we have co-designed these solutions, co-created with healthcare professionals from North, South, East, West, Vietnam, for example, and we have an evidence-based resource that we know could be slotted into that health service tomorrow and could make a difference to the families who often face huge financial catastrophe when a diagnosis of cancer comes. So if you're diagnosed with cancer also in a low resource context, that huge financial catastrophe. With the cutbacks in funding now for research in those contexts, it's huge challenges. So what we had hoped our programme of research would take and implement those resources into routine care. But now we are in a position where there are very limited resources for us to continue that work. So it's incredibly challenging, knowing that there's a problem, knowing that we've all worked together to create a solution, But now there's very limited space or resources or support for us to continue that work, to make a difference, to make an impact.
Aside from that digital support program that you already described, what kind of other areas are you researching into right now?
My research really started on looking at the long-term impact that a cancer diagnosis can have. So that idea of working in big population-based studies throughout Northern Ireland to understand that what is the long-term impact of cancer and what can that have. So very much identifying unmet needs, which one of the third highest unmet need for cancer survivors wasn't about aches and pains or medicine, was about living with the fact that you can't get insurance. If I book a holiday to Tenerife to unwind after my cancer diagnosis, that insurance is just going to be as much as the actual holiday costs.
And the worrying thing as well, and we were discussing this beforehand, then people start not taking out insurance and going on holidays, and then obviously they're putting themselves at huge risk if something does happen and that they then are not medically covered. So it's a spiral, it's a downward spiral almost.
And that impacts on everyone in the family, doesn't it? Because
Absolutely.
it's not, I mean, you don't usually go on holidays by yourself. So, that can have an impact. And an emotional impact.
Absolutely.
The stress that is associated with that.
And if you do take that chance and go, that you're living with that fear, and if something does happen, that's pushing you into an even worse financial position. So my research at the moment is really focused on understanding the long-term impacts of cancer and of how we can work together as academics, healthcare professionals, patients and carers to develop solutions that can be easily slotted into care.
Because you're working on a recovery package at the moment. What's that all about?
That actually was an earlier piece of research. So going back to some of Mark's ideas about how at Queen's we work and respond to need and policy, there was a real need coming from the health service to say people are surviving longer, which is great news, is a great story. But the actual current follow-up for care wasn't fit for purpose. So we were bringing patients up every 6 months for checkups, but actually that service wasn't meeting their needs. So we conducted a piece of research here at Queen's, which tried to understand the needs of that population. And we found that the current health service wasn't meeting the needs of our cancer survivors. So what we did was we worked with patients and carers and healthcare professionals and policymakers to bring some of that evidence to the table, from which then they developed this different model of support or care. So meaning that, for example, if you're a cancer survivor, you can now get rapid access back into the service if you are worried or concerned, that there should be better communication between the hospitals and primary care. But one of the real important things that was achieved as part of that recovery package was the fact that the hospital doesn't only check your medical needs, that there's a holistic needs assessment, so that when someone is cured, that we ask questions about your psychological needs, your social needs. Actually, how do you feel about all these changes in your body and your relationship? So from us working together to identify those needs, we could identify where the target or problem areas that helped those experts create a service, the recovery package that now meets the needs of that population.
Martin, at the moment, what kind of areas are you interested in looking into?
So we have just started some work on the area of Barrett's esophagus, actually with Olinda. Although we were working together in the past, we've reformed the band. So we're working in the area of Barrett's esophagus, which is not a cancerous condition, but for some people it can lead to cancer. For a minority of people it can lead to cancer. So this condition has similar symptoms to esophageal cancer. And because even it's a minority of people where it can lead to cancer, but because that is a possibility, of course it comes with the anxiety and the fear of developing cancer. So we're currently about to embark on a piece of work where we're trying to understand what that's like for people to live with Barrett's esophagus and how it impacts on their psychological well-being and that, fear of development of cancer. And again, then what can we do? What can we put in place to try and help people in that situation? So we're about to start that work actually, and that's part of an All Ireland esophageal network that Queen's has been contributing to. So that'll take place across the island.
So Martin, in terms of the research you're doing now, you're looking at caregivers, but caregivers come in all different shapes and sizes, don't they, and ages?
Yeah, so we're currently doing some work on adolescent caregivers, adolescents who have a parent with cancer. So they're in quite a unique situation in that, as you can imagine, psychologically, we're set up to look after children. Children are not set up psychologically to look after parents. That makes it, an interesting psychological context where we have adolescents who have a parent with cancer and they need some care from that adolescent. And what we're finding in our research is that it creates an element of loneliness for the young people. Not that they're on their own, because often they're living as part of a family. They go to school. They have lots of people around them. But of course, loneliness isn't being on your own. Loneliness is that feeling, that experience, that psychological state of not having someone to support you, someone to rely on, someone that you can invest in emotionally. We think that that's an area that needs addressed. And what young people appear to be missing in that context is the social support. And I think that's where services need to come in to provide that level of support, that peer group interaction that young people need, that they don't get from their current peers when they go to school because they're not sharing the same experience. So if they can create peer groups of people who have that same experience and that they can talk about those things together, then that might be a first step, at least, in helping. But that's an early stage research, and so we'll hope to develop that over the years.
You've all said that to some extent your career arcs have been affected by human interactions. I mean, if I was a researcher saying, should I be bringing my work to Queen's, what would you be saying to persuade me it's a good choice?
Yeah, well, I think we're in a good position here in Queen's because of the links that we have with the medical school and the nursing. I mean, having a medical school in-house kind of gives you access to lots of clinical academics who are working in those different areas, whether it's cancer or other health areas. And that's essential from the point of view of a psychologist. So if you're doing psychological research, anyone who does that type of work will know that one of the really crucial things to supporting your research is getting access to participants. And getting access to participants often means making friends with the medics and the nurses that work day to day with those patients. We have really good access to that. We have a hospital right beside us who are very keen in research and promoting research and are developing new forms of treatment that are at the leading edge of research. So there's a very strong willingness to be involved with psychologists to help develop that research. So I think that's one of the the great strengths, I think, of Queen's.
Similar questions to yourself, Olinda and Mark?
I would totally agree with Martin. I think one of the things is we do research that matters. We listen to healthcare professionals and we have that relationship that they can notice needs and issues, and there is always that communication straight across with the academic community where we're responding to real life need here. I think one of the big selling points, or one of the things in Queen's that we're fantastic about, is that environment where we work so closely with patients and carers. Patients and carers' voice are the priority, and right across the schools and the departments, at all our tables, whether that be module development or research, there will always be patients and carers who are very much part of that discussion. They are our colleagues and our partners, and I think that we do very well.
Well, it's a really exciting time to be in Queen's and looking at ways in which we're working together right across the 3 faculties. And so I think that's really important. We're not just sitting in our own faculty in our own ivory tower. So for example, we work very closely with engineering and physical sciences. We have a program called Momentum 10, which essentially is a Belfast Region City Deal Innovation Centre. And that's looking at applying secure connected intelligence coming from the physics and computer science, but applying it in the health and the agri-food space. So I'm really excited about that. That's a new initiative that we're doing. But again, it's that thing of us all working together here in Queen's University in Belfast, and the future is whatever we want it to be.
And just to conclude, I mean, for cancer caregivers, it's still a frightening time and be a very challenging experience. But I mean, looking to the future, are you hopeful about that kind of mixture, if you like, of scientific and medical breakthroughs on the one hand, and the growing understanding that you've brought of the journey, the shared journey that cancer caregivers go on with their loved ones, that things will change in the future?
It's the only way to go, because it's critical. We recognise what are the physical consequences, but it's those psychological consequences, and that's why Martin and Olinda, and I've worked with Olinda on a number of things in the past as well, because that's not unusual for us to do. So we don't see different departments, different faculties as a barrier. We see them as an opportunity. But we really need to be thinking much more about that sort of holistic approach. And it's particularly important. I mean, the caregivers essentially are replacing what the health service should be providing. So therefore, we need to be supporting them to make it as easy as possible to do that. The other big opportunity in Northern Ireland is on our phone since 2 weeks ago. Everybody, so the 1.8 million population of Northern Ireland, have their health record here. That makes a huge difference in terms of us being able to understand what the challenges are and then respond in the way you've heard. So we can do it if we have the information. We're able to work out what's the problem. We're solution. We do solutions. We don't do problems. We do solutions.
Olinda, would you share that hope?
Yeah, absolutely. We can't think of cancer as an illness that just impacts on the patient. Of course it does. If we want to work together as a globe to tackle cancer, we need to make carers part of those ideas and solutions on how we manage that.
And Martin, final word from you?
Yes, well, we know that cancer caregivers can have an impact on the well-being of patients with cancer. So it's not just about the well-being of carers, which is really, really important. And we know that carers experience higher levels of anxiety about the cancer that their loved one is living with. So we need to deal with that, because that's a psychological need that exists. But it's not only that, it's that we also know the experience of carers and how they think about the illness and what they experience emotionally about the illness can impact on the patient themselves and their psychological outcomes. So the two are absolutely connected, and we cannot treat one without the other, and we cannot separate these two things. So we're going to actually deal with cancer and the outcomes of cancer. We have to deal with all aspects of that, and that includes the carer.
Thanks very much, Martin. That's all we've got time for. Olinda, Martin, it's been fantastic hearing about all your work that you've been doing today and the difference that you're making for cancer patients and their carers here and around the world. This has been the Queen's University Belfast Research to Reality Roundtable. Thanks very much for joining us today.